What we're going to talk about tonight is a relatively newer alternative to spinal fusion that we have now available to us, which is lumbar facet arthroplasty. And what I want to do tonight is talk a little bit about that. Consider this over and what are its advantages, and then I think the more important thing is we could take some questions as well and just sort of talk about why it's right for people, and also why it may not be right as well. So I think that's also equally important in this conversation. So, why are we even talking about this is if you look in the world of orthopedics and you look at the joints in the body, right? Hip replacement or hip joint replacement is really where everything is at, right? If you've got a bad hip or a bad knee or a bad shoulder, in this day and age, nobody's talking about fusing those joints, right? Everything's a replacement. There's a joint replacement everywhere, but it's really been slow to evolve and adapt into the world of the spine. We do have some disc replacements that we place in the neck, very rarely done in the lumbar spine, but the facet joints have been largely ignored in all of this, right? They play a critical role in movement of the spine and stability, similar to a knee or a shoulder. Yet we've really not focused on that in the past, and yet here we are now talking about a way to address these bad facet joints with a new facet joint replacement. And again, that's the goal of the talk for tonight. And why is that important? And I'll just sort of try to make this as easy as possible. When we think about the spine and how it moves and how it's stabilized, it is a complex sort of relationship. Okay, so when we think about what we call the spinal unit, you have, and hopefully you can see my arrow, but you've got one bone of the spine, the disc that sits in between it. We call these the vertebral bodies. This is the disc. This is all in the front of the spine. And then when you go to the back of the spine, these two units are held together by these two bones in a tight capsule. And this is actually that I'm circling right now is actually the facet joint. It sits up and behind the disc. Okay. And so the disc that I show here is really important for acting like a shock absorber. It absorbs the body's weight when you stand up, and it has some shock absorb capability. And about 70% of all of the force or load when you stand that goes through your head is actually transmitted through the disc. So most of that is loaded through the front of the spine, while the facet joint sees a lot less, about 30%. But that joint is important to keep the spine from sliding forward, from slipping forward. We call that a shear force. And the facet joint is important for stopping that from happening, keeping everything lined up to the same extent. And it's also important for motion, right? It sort of limits that forward movement, which is translation, but allows the spine to bend forward in flexion, backwards in extension, side to side, and even rotate to a little extent. So the facet joints are critical to allow that to happen. And they're also critical and determine that sort of quality of it as well. And what I mean by that is the spine doesn't move forward and backward and side to side just like you're just slamming, like the motion stops and it starts, or starts and it stops. But think about like a higher quality kitchen drawer. Like if you try to slam it shuts pretty fast, and then sort of dampen at the end and soften and then slowly closes on its own. The facet joints let the spine do that as well. That's a quality of the motion, and that joint's really important for. So the purpose of what I'm talking about right now is these joints in the back of the spine are really critical to how the spine moves and really important to overall function of it. Now, they go bad, okay? They can go bad, and when they go bad, like with arthritis, they start letting one bone sliding forward on the other. Now, it can also go backwards, but for the purpose of our conversation, when the facet joints start to have problems, they develop arthritis, they start to degenerate, that one bone on the top can start sliding forward on the top bone, and that's called spondylolisthesis. And that arthritis as well, and that spondylolisthesis can cause spinal stenosis, and that's an irritation or a narrowing around the nerves, right? And so that can cause pain in the legs, numbness and tingling. The arthritis in the facet joints can cause back pain. And that's the condition we're talking about tonight. That's degenerative spondylolisthesis. The facet joints go bad, the spine slips a little bit forward. There's also narrowing around the nerves. You get pain in the legs, maybe a little bit of pain in the back. That's what we're talking about tonight. And that's due to those facet joints going bad. Now, interesting enough, this has to do more with the anatomy of the spine. Way too much to get into talking about this now, but this really happens almost all the time at the L4-5 level. This type of problem doesn't exist at L5-S1. Not going to get into it, but it just doesn't. It has to do with how those facet joints are oriented and anatomically. It's more common as we get older, right? This is arthritis. So we don't see this in young people. We see this in people that are older that develop it. And when you think about it now, this problem for us as surgeons is pretty common. And what really has been done kind of classically, what we would call the gold standard, so to say, would be to do a laminectomy, take the bone off the nerves, a decompression, and infuse it, right? That is just what's been done for so many years and is still done today, right? That's kind of the common treatment for degenerative spondylolisthesis and spinal stenosis. This slide is just really illustrating what happens in arthritis and in degeneration. We think about it as like a continuum, right? So early on in life, when you have maybe just a little bit of arthritis, it's not very bad. The disc in the front of the spine, as we showed before, maybe starts to degenerate a little bit, starts to collapse a little bit. It changes the forces on the bones in the back, which are the facet joints. Maybe it allows one to slide a little bit forward. They develop more arthritis. All of this in general then can lead to that spondylolisthesis where the bones finally start slipping forward on each other, spinal stenosis, further arthritis. Again, this is the problem we're talking about. Okay, so in today's world, right, the most common treatment that you would see for the problem we're describing would be a spinal fusion combined with a laminectomy. Okay, that's what I'd say the gold standard. Now, what we've learned in the recent times is that not everybody needs a fusion. So some people can get away with just a laminectomy. That's just removing a little bit of the bone in the back of the spine. But now we have a new alternative here where we can put in a facet joint replacement. So we can skip the fusion. We can take those bad facet joints out of the spine. They're not helping you very much at all. Still do the decompression, like decompress the nerves, and put this facet joint replacement system, which we're going to highlight in a second, that does support the spine so it can't slide any more forward after surgery, but still allows it to move. And in fact, the movement is fairly normal. The movement kind of goes back to the way it used to be, with good range of motion and good quality of that range of motion as well. So that's the benefit of a device like this in a patient who's got degenerative spondylolisthesis and stenosis. So for us, we kind of say this is the Goldilocks of treatments, right? Because as I mentioned, laminectomy alone can be done in some patients, but it has some problems, right? It provides no stability to the spine. So if the bone is already sliding forward a little bit, and then you do a laminectomy and take bone off the back, it actually can slide a little bit more forward. So that operation doesn't provide any stability. Now, it doesn't restrict mobility. It allows the spine to move normally, so that's pretty good. That's why that gets a green check mark. And it's got questionable outcomes, right? It works good for some patients, but not all patients, right? And we look at fusion, which is the far right side. That provides a lot of stability. That's what a fusion does. It stops all that motion. It locks it together. So that's excellent from that end. You have no more mobility at that spinal level. In fact, you lose mobility there, and that's a bad problem for a variety of reasons. And again, there's some clinical outcomes. It works good for some patients, maybe not all patients. Facet arthroplasty, as we talked about, is the best of all worlds. It provides stability where we want it, which is translation. It does not allow the bone to slide forward, but it also allows mobility. It keeps that spinal segment, as we talked about earlier, moving, and in fact, moving normally, which is really what we want. And it's got excellent clinical outcomes, and I'm going to show you that as evidence. Don't just take my word for it. I'm going to show you some scientific evidence to show you that that actually behaves better than a fusion in many of these patients. So what we're talking about tonight is actually this cartoon device you're seeing sitting right in front of you. It's actually not a cartoon, I guess. It's probably a more of a drawing of this or a real life vision of this in a sawbones. But this is that top system we're talking about. So this we're looking at a spine. That spine is moving with the TOPS device. It's allowing to move side to side. It's twisting there a little bit. It can bend forward. It can bend backwards. But what it can't do is slide forward. And that just has to do with the unique design of that system. So we do a laminectomy. So we take all the pressure off the back of the nerves, which we're going to show right here. So the bone is removed. You see the nerves, and that's what that is. And this is that device that's gone in. So that's bending backwards and forwards, side to side, rotating, et cetera, with all that normal motion. So We use it for people that have spinal stenosis, have symptoms related to that, and need stability afterwards. Okay, so that's what the device is for, and it allows fairly normal motion. And I'm going to show you some evidence of that in one of the slides. Like I said, you don't have to take my word for it. I'm going to show you some of that as well. Now, we did a study, and this is some of the details of that study. I was actually one of the investigators of that study where we compared how patients with laminectomy and spinal stenosis, I'm sorry, patients with spondylolisthesis and stenosis did if we did a TOPS operation on them, which is that facet replacement system, or we did a fusion. So we wanted to compare them in a fair way. So it's a randomized trial. So patients were randomly assigned to either one of these groups, right? Fusion or TOPS. They all had the same presentation, right? They had spinal stenosis and spondylolisthesis. It was typically at the L4-5 level. They had predominantly leg symptoms. So this isn't all just patients with back pain. This is patients with primarily leg pain, butt pain, numbness, tingling, can't walk very far, right? Classic spinal stenosis symptoms. And we enrolled them in this study. Okay. We then followed them very closely afterwards, and we're continuing to follow them. All right. We're going to follow them out to 5 years. Right now, we're about to publish the 3-year outcomes of this study, but I'm going to show you the 2-year outcome. And we looked at how they did one system compared to the other, and then also how many needed second surgeries, et cetera. So a very good study. This is designed with the FDA. They help tell you how you need to design the study. So it's very rigorous and a good look at outcomes. Now, what we did is we set up a very hard outcome to say it was successful. Okay, so it's a little bit confusing, but what we look at is what's called composite clinical success. Okay, so to say that there is a clinical success of fusion or the facet arthroplasty, a patient has to hit all 6 boxes. Okay, if they miss on one, they're not a success, right? So if you did an operation, the patient can't have another spinal injection down the road. They had to fuse if they had a fusion. If it's the TOPS, it had to keep moving. They couldn't have other adverse events. Their neurological status had to improve. It couldn't worsen, et cetera. So the key thing here is that to be a success, you had to have this very high bar, and you had to hit that high bar in each patient. And so it's a high bar study, so to say. And here is the outcomes. And this is, I think, very dramatic. Okay, so if you look at the blue versus the red, being high on the graph, so having a tall bar here is successful, and having a low bar is low success. So if you compared that composite clinical success, again, that's what we're saying is a successful outcome at 2 years, 77% of the patients that had a TOPS facet arthroplasty put in had success, while only 24% of the fusion did. So that is a very, very stark difference at 2 years, much, much more in favor of the arthroplasty. Now, for a variety of reasons, the FDA said, well, take the fusion part out of it. Fusion's confusing. Do patients even need to fuse? What about if you took that piece of it out? So we said, okay, let's just take the fusion part out of it. If you take that out, it's still way in favor of the facet arthroplasty. 78% of patients were successful versus only 53% of the fusion group. So this was a strong outcome at 2 years in favor of the facet arthroplasty. And it was so strong, in fact, the FDA declared it was superior. The FDA allowed us to say that the TOPS facet arthroplasty system was superior to fusion in return to outcomes at 2 years. And it got approved by the FDA based on these results. And now we have it out on the market today that we can use in very specific patients with spondylolisthesis and spinal stenosis. Now, here are some x-rays that I think really show what I'm talking about. So here is an x-ray of a patient before surgery. This is L4 and this is L5. This is a side view x-ray. And you can see that the patient may have spinal stenosis and may have this bone sliding forward L4 and L5. Hopefully you can see that. But there's good movement in this disc, in flexion extension, right? When they go backward, forward, you see that this disc moves, okay? Now, if I did a fusion between this bone and this bone with screws and rods, there'd be no movement. It stays still, okay? If you look at a TOPS at 1 year, this is a facet arthroplasty system here. That's what this looks like on X-ray. you can see that it moves, and it moves essentially the same as it did beforehand, okay? And in fact, if you look at it out to 2 years, you can see that it's still doing it. Okay, so 2 years, there's still good movement of this device. So what this just shows is that these outcomes, not only does it improve the neurological symptoms, it provides that stability that it doesn't allow it to slip forward, but it does let that spine move in a normal fashion with normal range of motion and normal quality of motion, which is key here, okay? And this is just showing the same thing, but with side bending, just looking at a different motion with that device here that you see here. And more importantly here, and it doesn't show it as well, is that the levels above and below it move normally as well. Okay, if I do a fusion, all the movement at the level of the fusion stops. It gets still, but the movement at the level above and below actually moves more. There's greater movement, and we think that results in greater degeneration of that disc faster, the so-called next level problem of fusions. This device theoretically stops it because there's normal motion with the device and normal motion at the level above it and even below it as well. So that's another good thing. What happens with patients over the long term? So what I showed you is 2 years of information. And you may say, yeah, that's pretty good, but that's not good enough, right? I want to know how this is going to do, a lot of years after you put it in me. Now, I will tell you, we're going to do that in the study we're in. We did 1 year data. We published that. We did 2 year data. We published that. We're about to publish the 3 year data, and we'll continue to do that after 5 years. But we do have some help from our European friends, where this is some results that they followed these patients with this device in out to 3 years, out to 11 years. So this is a long time after it was put in. And what you want to see is that when this bar is tall, that's bad. So before surgery, which is the far left bar, in these three slides, everybody's doing bad, right? They have surgery, they get this device in, they dramatically get better, so the bar gets really small. But if you look how it looks over out to 11 years in each one of these slides, that arrow continues to go down. So these patients continue to get better and stay better even out to 11 years. So that's pretty compelling. And the SF36, which is here, we want this bar to get taller. That's an outcome measure on how patients are doing. They get better and stay better to 11 years. So this is pretty strong with our 2 year data and even out to 11 years as well, in a smaller number of patients, obviously, but still gives a pretty good argument that this device works for the long term. Now, maybe less relevant for our discussion here tonight, but this doesn't just lock a patient into this and they can't have something else done. If I see a patient who's had a fusion before and has a problem above the fusion, they develop spondylolisthesis and stenosis, we see that. I still have an option. I can put that device in above a fusion, a TOPS above a fusion, a facet arthroplasty. That's what this shows. Here's a fusion, and here's the facet arthroplasty system above it. So we have tools to be able to use this around an existing fusion, which is kind of versatile, and this will get better going forward. Now, what about for me? So I think this may be the most important part of the conversation for you all as an audience. So if I see a patient who has spinal stenosis, so they're going to present to me with primarily leg pain, butt pain, foot pain, numbness and tingling in their feet, their legs. It gets worse with standing and walking. It goes away when you sit. And maybe doesn't have a tremendous amount of back pain, so to say, has a spondylolisthesis. That means one bone sliding forward on the other at L4-5 or above. I'm thinking about doing a laminectomy. So I'll take all the pressure off the nerves, get all that compression away, and then putting in a facet arthroplasty as opposed to doing a fusion. To me, it doesn't matter if the problem is stable or unstable. Again, that can be a little hard to define. But if you've been told you have an unstable spondylolisthesis and you need a fusion, that's what your doctor's told you. You can still have a facet arthroplasty. That's what we're talking about tonight. Doesn't matter if it's stable or unstable, which is great. The one thing that you have to have is you have to have at least some normal amount of disc still between the bones. So if it's L4 and L5, and if it's bone on bone and the bone is kind of slipped forward, that's a horrible person or problem to have a facet arthroplasty. We don't do that in that patient. We want to at least have some normal disc there. We say about 4 millimeters of height of disc before we can put it in, because we want it to move, right? We want the spine to move. If it's bone on bone, that spinal segment doesn't move at all anyhow. So putting in something that moves doesn't even work. It's not relevant, right? So the symptoms have to be more in the legs and the back. We want someone who's going to be pretty active, right? Because this thing moves. And I can do it if somebody's had a prior fusion at certain levels. I can also use it if somebody had a prior laminectomy in the past and they have a slip forward in stenosis, right? Maybe the laminectomy made it worse. I can still put this system in here. If someone had something like a Coflex or a Minuteman or these things that like pain management puts in, but the problem was primarily a spondylolisthesis and stenosis. This device can work for that, facet cysts, etc. So this is an alternative for me for a patient, which I used to always fuse for that problem. Now I can do this, and that's sort of become the main arrow in my quiver, so to say, for that problem. So I want to stop by just giving you my contact if anybody's interested in talking to me more about this. Obviously, if you go to the Cleveland Clinic website and look up the Department of Neurosurgery or the Center for Spine Health or put in spine surgery, etc. You're going to find me there. There's an appointment link if you need it. There's an appointment hotline number. This is my direct office number that I have up on the screen. I'll leave this up for everybody. And then obviously there's the contact for Premia Spine. They're the people that make this device. There's only one of these type of products out on the market today. There's no other facet arthroplasty that's available. So you could say, well, is there other competition? There's not. This is it. Maybe some will be more FDA approved down the road. But as of right now, this is our best and option, really only option that's out there right now. And so I'll leave that contact up as well. So I'm going to stop talking. And I think again, is one of the more important things we'll do tonight. Let's start going through some of your questions, and we can take it from there.
Hey, great. Let's do that. Dr. Steinmetz, thank you. This is Jeff. I'm sorry I had to join a little bit late
Hey, Jeff.
due to travel. But an excellent explanation and an overview of TOPS. That was really good. So thank you for doing that. We do have a handful of questions here. Let's start with, here's one. What is lytic spondylolisthesis?
So a lytic spondylolisthesis is it's not what we're talking about tonight. So again, what we're talking about tonight is we call it degenerative spondylolisthesis that's due to arthritis, right? Lytic spondylolisthesis is something that is due to a type of fracture, a break in what a bone we call the pars interarticularis. It occurs at L5S1. It's rare anywhere else besides L5S1. It's due to something a patient is born with. When you're young and you're an adolescent, you typically develop the break in that bone, the pars interarticularis. It's not trauma. It's just we often see it in gymnasts or athletes when they're adolescents. That bone breaks. Someone may not even know that, but they went through an episode of very bad back pain as an adolescent. Then as someone ages and over time, the disc starts to degenerate, and then the bone at L5 slips forward at S1 and compresses the nerves going out to the legs at L5S1. So it's a similar idea in that one bone slides forward on the other idea, but it's due to more to a break in the bone, a break that occurred way earlier in life, and it occurs at the L5S1 level. It doesn't cause the same symptoms or the same problems, so to say, as we're talking about tonight.
Yeah, very good. Here's another question. This patient is inquiring as to whether they're a candidate for TOPS. Has a grade 1 spondylolisthesis at L4, L5 with preserved disc height, but severe radicular pain, stable 5.7 millimeter disc, although that has decreased since last scan from 5.8. Stable facets, but recently had a laminectomy at L4, L5, but has continued with radicular pain. 85% legs and buttocks, about 15% back, lower back. So based upon that description, would you consider that a candidate for TOPS?
I would say yes. I mean, there's some other things that need to be considered in the evaluation to make sure that, the area at L45 where you had your laminectomy was the cause of your symptoms. And that's pretty easy to figure out with seeing you, talk to you, looking at your image. But assuming that there's still compression of the nerves at L45 because the laminectomy couldn't get that fully cleaned out, yes, absolutely TOPS would be a candidate. You could be a candidate. It would allow a more aggressive nerve decompression because you could remove all of the bone around the nerves, the so-called facet joints that are bad. Maybe there's still compression of the nerve below them. With TOPS, you can take the facets out completely, decompress the nerves in a much better, more thorough way, put the device in and provide that sort of facet replacement and that motion afterwards. So it sounds like yes, the answer would be yes.
Yeah. And what you said is really the secret to the success of the device, isn't it?
It is.
It's
Yep.
that aggressive wide decompression, removing all those posterior pain generators that really,
Yep. That
yeah,
That's
go ahead.
exactly right. That's the limitation of laminectomy for patients with spondylolisthesis and stenosis, which I do in the right patient. But the challenge there is you can't you've got to limit the amount of bone you remove because you can't remove too much and then cause instability because that will result in the bone sliding forward. So it's more of a limited nerve decompression. You can leave somebody after surgery still with residual compression, and that may be what happened there, and kind of what Jeff is alluding to with a TOPS procedure. You take all the bone away. There's no bone between L4 and 5 anywhere left. The nerves, I can see them from start to end. I know they're decompressed, and then I can put that device in to provide that stability afterwards and motion.
Yeah, absolutely. Here's a good one. How much posterior muscle strength loss is there since all of the lumbar muscles attached to the dorsal lamina will lose their attachments at that level? I ask because maintaining strength in my posterior muscle chain is a priority as a rock climber.
It's a great question. I mean, I don't think we know that from a pure sort of biomechanical standpoint. And look, we know that. So a couple ways to answer that. One, laminectomies, which would have an equivalent muscle dissection, been done forever. Over 100 years, right? And people have had them and live a quite normal life. But there is trauma to the musculature. There's no question about it, and there would be some loss of isolated muscle strength. The question for the rock climber is there enough clinical change for you to result in any difficulty with rock climbing? That's hard to answer. But as of today, clinically, unfortunately for this device, there is no minimally invasive option for this. This is a true exposure. So there would be some trauma to the muscle, and there may or may not be a clinical result of that for someone who's a rock climber, which is not common, right? For the average human being, this would have no consequence on that muscle strength to have any impact later on in life or what you do. But a rock climber, that's a special activity with a lot of strength. And so perhaps that could, any kind of lumbar surgery could hurt you. So it's not just this device. I think it may be any lumbar surgery could have the same result. Hopefully that answers that. There's no good study to measure what kind of objective strength is lost, and especially for someone with such physical activity as that.
Yeah. Here's a common question that I'm sure everyone would like to hear is how about recovery time for TOPS? And I would add versus fusion
That's
procedure.
a great question, and I,
Yeah.
I I get that all the time when I see patients for this, and I always tell people it depends on how you define it, right? Recovery is a definable problem because there's a lot of equivalence and there's a lot of difference. Okay, so how is it the same? When you have back surgery, like that's required with a fusion or a TOPS. You have an exposure, you have an incision. In my opinion, it takes about 3 months for either one of those until most all of the surgical discomfort in your back is gone. It gets dramatically better after about 2 weeks and it continues to improve. But in most of my patients out to about 3 months, you still have some element of back pain before it goes away. And I would say there's an equivalence there between the fusion and the TOPS. Okay. Here's the difference. If I put a TOPS in somebody, once I get that device in and I'm kind of happy it's in there, it's working, the wound's healed up after a couple weeks, I really don't put you a lot of restrictions on you. I just say, go get back into life. We want this thing to move. It's stable. And, once you kind of get over the back pain, even if it's at a month, just go live your normal activities. And I'm not worried about anything else happening down the road, right? I'm not worried about it healing anymore. We have a good, happy, healthy device. You've got a good, healthy life, and you're on your way. With a fusion, you got to remember that what the screws and rods aren't a fusion. Okay, the screws and rods provide stability. The bone graft that gets put in during the fusion procedure, that has to heal to new solid bone, and that's the glue that holds that spinal segment together for the rest of your life. That takes about 12 months to fully heal and mature, right? So I'm worried about my fusion patients healing that bone for a full year after surgery, and you're kind of not out of the woods from that operation out to there. So although I still may say you may have some discomfort for 3 months, I'm having you baby your spine along during that 3 months. I don't want a lot of exertional activity. I don't want you doing a lot of bending, lifting. I'm much more restrictive on your activities out to 3 months. And then even have some consideration out to 6 and out to 12, and still got to follow it out to 12 months. And so I think that's the big difference in the recovery here, okay? Is that for my fusion patients at 9 months, a fair amount of patients, 9, 10% fail their fusion. I got to go back in and reoperate on them because the bone never healed and the screws loosened. Once I get that tops in, you're over the surgical back pain, go get back to an active life, and I'm not so worried about it at all anymore. So that to me, I hope that answers the question. That's the big difference.
Yeah, great answer, and a great question. How about we have time for one more question? Is there a limit to how much spondylolisthesis can be corrected by TOPS?
Yeah, so great question, and I want to provide a clarity statement on that. Number one, TOPS cannot necessarily correct a spondylolisthesis. Okay, so there are times when we do a fusion where we actually take the bone that slid forward and we want to try to pull it back into alignment. Now, I can argue strongly that most of the time that's not needed, nor does it provide any benefit. But just for sake, because I can apply a force to the spine, I can actually correct it. TOPS doesn't necessarily correct it. It kind of holds it in place and allows it to move normally. So I just want to make sure I'm saying the right thing to whoever asked that question. The indication for this device is a grade 1 spondylolisthesis. So if you're above a grade 1, a grade 2, grade 3, grade 4, obviously it is not indicated. It cannot be used for that. So up to a grade 1, that has to do with a percentage of the one bone sliding forward on the other. A grade 1 is anywhere from 0% to 25%. So anything above 25% of one bone slipping on the other, we don't use it for that. So a grade 1 spondylolisthesis.
Additionally, I would just add the question, could you explain, just like you did that, what you look for disc height when you
Yep.
utilizing TOPS as well?
Yeah, and let me see if we can go back in slides just so I make sure we're all on the same page with what we're saying here, what disc height is here, okay? So when you develop a spondylolisthesis and stenosis, the disc, which is right here, collapses. Okay, you lose the height of this disc. It starts shrinking down and down and down and down. And you got to remember that thing is also important to move. Okay, if you go from a point where you've got a good normal tall disc, like maybe we're seeing here with good height. I don't know if my arrow's coming up here with good height. If it gets to a point where those bones are fully bone on bone, the disc is 100% collapsed, it's one bone fully sitting on the other bone, there is no movement in that segment anymore. You don't get any benefit of putting tops in. So we wouldn't put it in that person. So you need at least 4 millimeters. We can measure this. You need at least about 4 millimeters of height of disc. So measuring from top to bottom, there's got to be about 4 millimeters of disc in there to know that there's enough movement still in that disc to put the TOPS device in. So Jeff, does that seem to make sense? Do you think everybody's kind of getting what I'm saying there?
Yeah, I think so. I think that
Okay.
was important. I
Yeah.
like what you said around how do you describe up to a grade 1 spondylolisthesis
Yeah.
as well. Then on the other end of it is also disc height requirement for, and
Yeah, that's exactly right. We want
yeah,
to have less than grade 1 ideally spondylolisthesis, which the good news is that's almost every degenerative spondylolisthesis that exists. They're almost all grade 1. It has to do with the anatomy of the facet joints. Very complicated for this conversation, but anything above grade 1 typically is some other cause, like the lytic one we heard before. Those can become grade 1, grade 2, grade 3s. So they're almost all grade 1s, and for the most part, people have some disc left there. So I'd still say the majority of patients I see have have a grade 1 and have enough disc to put this device in. The 80% of the people that I see for this, that they are candidates.
yeah, great. Well, listen, that's all we have time for tonight. Dr. Steinmetz, thank you for your time once again. Thank for taking part of your evening to cover this. And for those that joined, thank you for taking control of your care and seeking out this information. It's really important that you're educated. Um, and I don't know if we want to go back to the final slide.
Sure.
If you're um, seeking care or want to be in contact with Dr. Steinmetz, there's his information. And also, if you want to contact Premia Spine directly, you see Shelby George's contact information there, and we can help you If you happen to be in the area of the country that doesn't make sense for you perhaps to see Dr. Steinmetz, we can refer you to another physician that has been trained and is highly educated on the TOPS technique and device. So
And sorry, go ahead, Coach.
no, go right ahead. Go right ahead.
And I was just going to remind everybody too, it's also quite easy to look at our Cleveland Clinic website, clevelandclinic.org. You can simply search me, search spine surgery, neurosurgery. I'll come up. You can have just a link to an appointment if that's easier. There's a more generic Cleveland Clinic appointment line if that's easier. We do a significant amount of what we call virtual or video consults for patients. It is important that there's some states we can't do that, so it's not uniform if you try to contact that for us. But there are many times where I can see you just over a video screen and you don't have to physically come to Cleveland if you live out of state. But I just want to mention it is state dependent, so that's not a uniform thing you can do.
Great, great. Well, once again, thank you, everyone. Appreciate it. Hope everyone has a great evening, and we look forward to being in contact with you guys again sometime in the near future. Take care.